So I get the privilege of introducing people that I have known for millennia. And longer. But rather than do it in a personal way, I'll do it in a professional way because most of you have not known them for that same length of time. We're going to have a similar setup to the program for the afternoon as this morning. Two speakers who are going to educate us on various issues related to the overall goal of today's conference. And then have someone else come up and do some commentary response to that and open it up for all of us to participate with questions and comments. So our first speaker for the afternoon, who was our morning MC, Master of Ceremonies here, Professor Grodin is a professor at the School of Public Health, where I am as well, and at the School of Medicine, and has for many, many years been involved in issues that are either central to the things we've been talking about today or tangential to them. And what he's going to be focusing on, though, for us this afternoon is the issue that people have referred to a lot with the morning program, but we didn't get into yet, which is diagnosing and treating post-traumatic stress disorder and TBI injuries. So that we've focused a little bit this morning on some of more of the physical manifestations and symptoms that veterans have experienced. And now Michael is going to balance some of that education for us this afternoon. So, Michael?
Okay, thank you very much for that kind introduction. What I plan on doing is something that's quite a challenge, which is in 40 minutes. I plan to give you an overview of a very complicated topic, which is post-traumatic stress disorder and traumatic brain injury. And I'm going to try to make it as simple as possible so that when you come away, you'll have a concept of what this is, okay? And I'm going to try to give some analogies that'll make it more clear for you, the way I talk to my patients. I've spent 30 years caring for survivors of torture and refugee trauma, Holocaust survivors, and so I'm very familiar with the signs and symptoms of not only brain injury, which about 30 to 40% of our refugees have, but also post-traumatic stress disorder, which probably 80% of our survivors of torture have. So, first, let me thank that some of this data, the source of my data is the Department of Veterans Affairs and the National Center for Post-Traumatic Stress Disorder. And I want to thank Jared Beaumont, who was my graduate student who helped me put together the slideshow, because they don't get credit enough. Since 2001, 1.64 million troops were deployed for operations Enduring Freedom and Iraqi Freedom in Afghanistan and Iraq. And this is an unprecedented in the history of the all-volunteer armed military, the number of military being deployed. Of those 1.64 million troops, 300,000 are diagnosed with PTSD, post-traumatic stress disorder, or major depressive disorder, and 320,000 have traumatic brain injury. 1/3 of all deployed have one condition, and 5% have all three. So the first thing I want to talk about is post-traumatic stress disorder, get you on a firm footing on that, talk a little bit about traumatic brain injury, and then talk about what we do to treat, because we know an enormous amount about how to treat these conditions. First of all, according to DSM-4, which is the Diagnostic and Statistical Manual for Psychiatry, the diagnosis criteria for PTSD are exposure to a traumatic event in which the person, one, experiences, witnesses, or was confronted by death or serious injury to self or others, kind of the definition of a combat mission, and responded with intense fear, helplessness, or horror. So those are the pre-exposure traumatic conditions. Then following the trauma, a series of core features of PTSD are diagnosed. Persistent re-experiencing intrusive symptoms, the so-called re-experiencing phenomenon, which includes flashbacks, rumination, inability to get thoughts out of their mind, as well as nightmares and flashbacks. Numbing and avoidance of stimuli, which is an attempt to deal with the hyper-irritability and re-experiencing. There's an attempt to avoid stimuli, to not go out, to not get re-exposed, to not get triggered, and persistent hyperarousal symptoms, hypervigilance, being on guard, and symptoms lasting for greater than or equal to 1 month. Now, to be a little more specific about those three areas of the PTSD symptoms, one is re-experiencing symptoms. These are recurrent and intrusive distressing recollections, Ultimately, I'm going to give you my goal in treatment, in fact, is to get people to remember what happened without reliving it. Remember what happened. You can't get rid of the memories, and that's part of the avoidance problem, is when they try to avoid thoughts, you can't avoid some thoughts and other thoughts. You just avoid all thoughts, in which case you become numb, you become shut down. So re-experiencing is recurrent and intrusive distressing recollections, which can become during the daytime, which is acting or feeling as if the event has reoccurred. So you hear a siren, you hear an explosion, and you're back. Literally, in that second, you're back in the at-risk situation. Or nightmares, and people find they can't go to sleep or they have problems falling asleep because of fear of nightmares. Avoidance and numbing symptoms, again, this is the phenomenon of avoiding thoughts, feelings, or conversations about the event, avoiding activities or places or people that cause reminders, which causes one to shut down and not engage with others for fear of getting triggered or fear of having symptoms recur. And then these disturbing hyperarousal symptoms, difficulty sleeping, irritability or outbursts of anger, and difficulty concentrating. Now, what do we know about the epidemiology of PTSD? So there was a quote this morning where our speaker said that something like 5% of prevalence of PTSD, but this is the epidemiology of PTSD for the normal population, for the US population. So I'm not talking about people who have experienced trauma, combat trauma. 61% of men and 51% of women experience a trauma in their lifetime equivalent to what would be the precondition for PTSD. More than 25% experience multiple trauma, and women exposed to trauma are twice as likely to develop PTSD. Nobody knows exactly why that is, by the way, and we can talk about that in questions and answers. But there's a lifetime prevalence of PTSD in the population of 6.8%. So that's the background. 9.7% in women, 3.6% in men. That's the epidemiology in the normal population. Conditions following a traumatic event can lead to many different things. Post-traumatic stress disorder is one phenomenon, but depression, which often goes along with PTSD, we have about a very high comorbidity between major depressive symptoms and post-traumatic stress disorder. Substance use and abuse, especially alcohol, oftentimes starting as a way to try to numb, as a way to try to decrease the hyperirritability. Of course, it doesn't work and it causes more problems in the long run, but it's a self-medication. Panic disorder, phobias, and people can even have transient psychotic reactions. Why PTSD is important? PTSD is distinguished from other psychiatric disorders in that there is a known etiological component, an event that involves a life-threatening event, serious injury, or death. Specific examples are very common are war zone exposure, assault, rape, torture, natural disasters, and serious accidents. The difference between the combat situation and some of these other situations is we have often what's called complex PTSD because people are unable to escape from the trauma. So when you have a natural disaster, you have a single event. So a certain percentage of people will have PTSD after that, but it's pretty easy to treat actually. The problem is with people who have recurrent exposure and are trapped and are unable to get out of that exposed situation have much more difficult problems. They tend to dissociate, they tend to have much more difficult problems of meaning and psychological problems. Now, this is what I want you to take away. This is one of the main messages, that PTSD is actually a failure to adapt. The normal response, it's natural in adaptation to have a strong reaction when one's life is threatened. That's protective, okay? So it's a normal reaction when you have, in a life-threatening situation to have a fight or flight response. Your autonomic system, your amygdala gets triggered in your brain, and this is a protective, right? The problem is these reactions should decrease when the threat is no longer present. And this doesn't occur with people with PTSD. So PTSD can be seen as a failure to adapt to a situation where you're no longer in that combat situation. So when I treat my patients, what I like to tell them, and this is a metaphor that you can take with you, which I think is, if not totally accurate, pretty good example. When you're walking along in the jungle, or when you're walking along and you see a lion or you see a tiger, what happens to you? What? Yeah, you run, if you can run, or you freeze. But your heart rate goes up, you're on guard, your respiratory rate goes up, you have an enormous response, okay? That's what happens when you're in an acute situation. But when you go to the zoo and you see a tiger that's behind the cages, you don't have that response, right? Because you feel safe. The problem with people with PTSD is, even though they're no longer in the situation where the tiger's outside the cage, they're acting as if it is, all right? They're acting as if the tiger's outside the cage. And what we need to do is put the tiger back in the cage. So I don't know if that's helpful to you, but it makes a lot of sense to my patients. Combat exposure in the National Comorbidity Study is the lifetime prevalence of PTSD. Remember I told you it was like 5-6% in the normal population. It's 39% among male combat veterans. This is all VA statistics. And a male combat versus all other male trauma has a higher lifetime PTSD prevalence, greater likelihood of delayed onset, and a greater likelihood of unresolved symptoms. Okay? So combat is the paradigm example of the kind of things that cause PTSD. The prevalence of PTSD amongst veterans. So the Gulf War veterans, a population sample of 11,000 Gulf War veterans, had a current PTSD prevalence of 10%. Afghan War veterans, a current PTSD prevalence of 6 to 11%, and Iraq War veterans, 13 to 18%, and 12 to 20%. So it's significant. The Department of Defense rates of mental health issues, just to be a little broader, between 2003 and 2007, under mental health assessment team findings, found self-reporting of PTSD symptoms of about 14%. So it's pretty close to exactly what is found by doing external examinations. PTSD, depression, or anxiety is 16.7%. Of service members positive for mental health problems, more than half would not seek care. Okay, more than half would not seek care. So this is going to be a problem in terms of getting people to be diagnosed and put into the treatment mode, where again, we know a lot about PTSD and we know how to treat it. Post-deployment health assessments, significant mental health problems, 38% in the Army and 31% in the Marines. Now this may be a phenomenon of samplings, different sampling techniques. Now, there are a lot of stressors in the military besides combat. Obviously, life-threatening combat deployment is probably the paradigm, but there's other loss, there's interconflict, there's lack of control, and military sexual trauma, which we said is an independent factor for PTSD. 50% of women and 29% of men have experienced offensive sexual behavior in the military. This is all from DoD data. 31% of women and 7% of men have experienced unwanted sexual attention, and 6.8% of women and 1.8% of men have experienced unwanted sexual contact. It's a big problem. So how do we go about assessing PTSD? Well, one is we do clinical diagnostic interviews, and they're pretty good instruments at this point where we know how to do Hopkins symptom checklists. There's various symptom checklists and interview diagnostic techniques that we use, as well as psychological testing. And there are even neurobiological testing that can be done to show that people have this hyperarousable, hyperreactivity, that they're still acting as if the tiger's outside the cage, okay? So they have increased susceptibility to hypervigilance, hyperreactivity, and re-experiencing. Now, what are the consequences of PTSD? Individuals with PTSD have, again, an array of symptoms, but they have elevated risk of mood and other anxiety and substance abuse disorders. They have greater functional impairment, so independent of what other problems they have, the comorbidity of having PTSD causes those problems to be more problematic. They have reduced quality of life, and they have elevated risk of poor physical health. This is the mind-body connection. This is the comorbidity of PTSD. These are odds ratios of PTSD versus no PTSD. And you can see the men versus women, and some of this is an exposure technique. But the only thing I want you to take away is that there's an enormous comorbidity of PTSD with major depressive disorder, dysthymia, which is a condition just under depression, major depressive disorder, generalized anxiety disorder, panic, simple panic, social phobias, alcohol and drug use. So there's a whole array of mental health problems that go along with PTSD. Combat-related PTSD, as opposed to PTSD due to other events, is more severe. So when we study combat veterans, as opposed to other people who have PTSD, there's increased unemployment rates, increased veterans being fired, increased divorce and separation, increased spousal abuse. And the National Vietnam Veterans Readjustment Study also increased unemployment, decreased health and well-being, increased limitations due to physical functioning, and increased violence. So there's a whole array of issues, and we can't isolate out just one factor as an independent variable. Now, many people say that PTSD, you get after the 1 month period, after the 3 month period, that there's an incidence of PTSD, but PTSD can come on much, much later. It can be quite delayed. And 214 Israeli combat veterans were assessed at 1, 2, 3, and 20 years post-war, and there's delayed onset, even out 20 years out, where you can have your first onset of PTSD symptoms. Again, you store in your amygdala the reaction, and something triggers it, and you start to have your PTSD symptoms. It's unclear what triggers it actually, but it can start up, again, having symptoms of PTSD. And so we can have long delayed onset. Ultimately, what we want to do is get the amygdala, which is this hyper firing area where the tiger's out, to be put in the hippocampus, which is the memory area of the brain, where it's protected, where we have the memory, where we remember without reliving, where we can have the memory without reliving each time we think about these things. The course is variable. The onset usually occurs within 1 to 2 years of the trauma, but can be quite long delayed. 3 years in people who have received treatment, 5 years in people who did not receive treatment. Symptom exacerbation is common in chronic PTSD, and new trauma or life events can reactivate symptoms. So somebody can not have the symptoms, but then have a car accident or something, and then have it re-stimulated. So this is by King and from the work for the National Center for Post-Traumatic Stress Disorder. There's a very complex interaction of pre-war risk factors, war zone stressors, post-war resilience, PTSD, and they all interact and they all interrelate. So it's quite complex, even though the end result we can have pretty well described. What are the predisposing factors, and what are the war zone stressors and the post-war activities? People had lives before they went into the military. People had other stressors, and so it's very important to realize it may be quite complex. Risk factors for PTSD have been studied quite extensively, and there's pre-traumatic risk factors. So there's a higher incidence amongst female. Some people think that might be related to sexual violence, and so it's underreported, so it may not be an estrogen effect, which some people think it's purely a function of hormones. Childhood trauma, people had childhood trauma before they went into the military, obviously are at risk for having more problems. Previous psychiatric problems, we think there may be some genetic predisposition. Lower socioeconomic status may be a function of coping mechanisms and access to health care as much as it is anything else. Peritraumatic, greater perceived threat or danger and helplessness, unpredictability and uncontrollability of traumatic events is a setup, and lack of social support and life stress after the fact. So it's pretty clear. Now, post-traumatic stress disorder and traumatic brain injury obviously go hand in hand. Common symptoms of post-traumatic stress disorder and traumatic brain injury are decreased concentration. We already told you that because of the PTSD, you have a numbing tendency to numb, to try to decrease the hyperirritability, the re-experiencing. And then, of course, the head injury, the traumatic brain injury, also causes problems in concentration. Agitation and irritability is very, very common. Insomnia is a problem with traumatic brain injury and a problem with PTSD. Social isolation and detachment, found in both. Impaired memory, affect and mood disturbances, okay? So actually, I'm often asked, because I testify in court a lot for refugees and asylum seekers, how do you know that somebody's not malingering? This comes up, which is a very rare phenomenon in my experience. But it's normal to have impaired memory. So someone who remembers everything about their war-related trauma experience is someone to be suspect. It's normal not to remember things, to have lapses, to have problems of timing, and so that's a normal phenomenon. And then affect and mood disturbances are very common. Pre-injury traumatic brain injury factors, pre-injury traumatic brain injury factors, baseline cognitive function, Psychiatric problems, so these are the same pre-injury traumatic factors as we have for PTSD. Risk-taking and novelty-seeking behavior, premorbid behavioral problems, social circumstances, neurogenic factors, and age. So now I want to talk a little bit about traumatic brain injury. We have ample time for questions and answers. What are traumatic brain injuries? Now, traumatic brain injuries are a complicated evolution also. So you have, so let's see if I can see this. You have a traumatic brain injury, which causes hemorrhaging, which then causes vasospasm. Because of the hemorrhaging, the vessels clamp down to try to prevent more bleeding, which causes decreased cerebral blood flow. Decreased cerebral blood flow causes ischemia, or lack of oxygen, which causes more brain injury, which causes more hemorrhaging, which causes more vasopressin. On the other side, we have a release of amino acid neurotransmitters, which cause metabolic demand to go up, glucose metabolism to go up, which causes risk of ischemia, which causes more brain injury. And so we have these circles and circles of reinforcing phenomena for traumatic brain injury. And we know where the traumatic brain injuries are because these have been mapped. And so they're in the frontal, I mean, you don't need to know the actual areas, but in the frontal area, on the cerebral cortex, and oftentimes in the so-called cerebellar area. So this can cause balance and other problems. And this is cognition and visual memory problems in the substantia nigra. Now, what do we know about the brain injury prevalence in Operations Iraqi Freedom and Enduring Freedom? 88% of improvised explosive devices in mortar attacks had evidence of traumatic brain injury. 47% about the head. 97% of explosions around the, 53% around the head or neck. It's not important that you know the details, but there's an enormous level of traumatic brain injury. An at-risk group of 59% had traumatic brain injury. At least 20% of the wounded had some degree of brain injury. So this is an incredibly prevalent phenomenon. The most prominent traumatic brain injury symptoms, again, they cross over with PTSD symptoms, but balance and dizziness, that's that problem in the cerebellum when you get injured in the back of your head. Headaches, which are a recurrent phenomenon. Visual changes, particularly sensitivity to bright lights. Memory and cognitive deficits. Irritability, sleep disturbances, and tinnitus and ringing in the ears and decreased hearing from the loud ordnance. Oh, hold on. Okay. The incidence of PTSD goes up with the degree of traumatic brain injury also. So when you have level 2 mild traumatic brain injury, you have a 47% comorbidity of PTSD. So they go hand in hand, they're interrelated. A little bit about substance use syndrome in the military. Jacobson in 2008 studied alcohol use among 48,000 military personnel deployed to Afghanistan or Iraq, and combat exposure were associated with increased alcohol problems, binge drinking, and heavy drinking. 2008 survey of over 1,000 on alcohol use in the Army found an increased incidence of binge drinking, especially those exposed to trauma with marital problems and recently returned from combat. This is all part of recognizing the problem when somebody comes back, that they're at risk, and trying to do preventative measures. Comorbidity of PTSD and substance use disorder is clear. In contrast to just one of these disorders, you have a worse treatment outcome when you have comorbidity. You have greater psychiatric and medical, legal, and social problems, higher aggression, domestic violence, greater substance craving. So this is not unusual. There have been a number of techniques, and I'm not going to go into them all, but we know an enormous amount about how to treat PTSD. We know an enormous amount about how to treat substance use disorder. We know a lot about how to treat traumatic brain injury. There are whole protocols which are really validated that are put together by the VA. Seeking safety is a psychotherapy technique which is used for people with PTSD and substance abuse. It's a manualized concurrent treatment of PTSD and cocaine dependence. There's been volumes of material, collaborative care, video intervention, cognitive behavioral treatment. It's not important that you understand Probably they all have elements of the same kind of behavioral, cognitive behavioral structure and social support systems. PTSD treatment options are usually some type of psychopharmacology as well as some type of psychotherapy. Exposure therapy in a controlled way is taking somebody back to the event, which is done in various ways, but get them to re-experience again in a safe environment so that they don't relive it, but they just remember it. So that's a way. Cognitive therapy, anxiety management, EMDR, which is a technique we use for eye movement desensitization, and pharmacotherapy is certainly an adjunct. And I think we underutilize, actually, SSRIs as a way to get to the psychotherapy. When somebody's in the hypervigilant state and they're so hyper-aroused, you can't deal with them. And I think actually talk therapy is not only not helpful, but makes them worse. I think first we have to get under control the safety, the aspects of the acute hyperarousal, get their life together, the support systems, and then we can talk about reintegrating. Cognitive behavioral therapy is well studied by the VA, a broad class of interventions, again, prolonged exposure and psychoeducation, anxiety management, cognitive restructuring, a whole series of techniques which are very well studied and very well validated. Prolonged exposure, we use breathing skills, learning to manage the anxiety. There's a whole array of techniques we can use. In vivo exposure, imaginal exposure, they're even doing some kind of virtual reality kinds of things, so trying to get people to actually even re-experience what it's like to be in the combat situation in a safe environment to kind of re-expose people. Cognitive processing therapy, processing the trauma, challenging thoughts, cognitive restructuring, these are all very well studied. Which therapy to use? Not a lot is done. We know a lot about what works, and I think they all come together in the same kind of end result. But most important to use evidence-based therapy. Dropout rates are similar, and there's a fair problem with dropout rates. Therapist knowledge is probably as important as anything else, and the patient preference. So different patients will go to different types of treatment. Actually, pharmacological treatment, certainly alone, is not as effective as cognitive behavioral therapy. So just giving somebody drugs is not going to treat this. Giving somebody drugs and doing cognitive restructuring is helpful, okay? So there's a place for psychopharmacology, which I think is very important, but it's necessary but not sufficient. It's useful for treating the comorbid conditions of depression and anxiety. Generally, it's accepted by patients and may be obtained from any prescriber, whereas cognitive behavioral therapy requires somebody who really knows how to do it. And there are a whole array of SSRIs and various drugs which are quite effective. There are multidisciplinary rehabilitation programs. This is the Polytrauma VA website, which is quite good, and long-term support and the Brain Injury Association. So I'll leave that on for a minute if you want to write those down. The question of people who don't do well. There are different theories for treatment failure. It's not clear we know exactly why. By the way, I don't like the word treatment failure. The treatment didn't fail. The treatment failed the patient didn't fail the treatment, right? The treatment failed the patient didn't fail the treatment. Different kind of approach. But chronic PTSD, some would argue, is due to biological changes or the length of disorder. I don't think that's true. Patients are not ready for treatment. I don't think that's true. I think it's a matter of how you engage them and when you engage them. And we don't have the right treatment yet. I think that's not true. I think we need to try many different approaches, but these are common theories for treatment failure. Barriers that we can do something about, though, are motivation to change. So this change in attitude we talked about, and I think that'll become important in terms of the suicide question, in terms of that this is a known common phenomenon, and we need to be aware of it. Treatment beliefs are not addressed. There's a poor therapeutic alliance. This takes time. It requires establishing safety. And it may take months before I even touch on the trauma when I talk to patients. So we want to talk about what's here and now, what their problems are, and in the context of that, maybe go back, but not even for years sometimes, go back into the, okay. And be aware of cultural differences. So this is also very important. Obviously, the refugees I work with, it's by definition, but there may be different manifestations of symptomatology, which is very different based on your culture, based on your background. So somebody of Hispanic background may have a different sense of what it's like to go to a mental health provider than someone from another environment. And it's very important to keep those cultural differences in mind, both by the provider and by the patient. This was touched on, but the new regulations from the Department of Veteran Affairs, the department will grant compensation to those with PTSD if they can simply show that they served in the war zone and in a job consistent with the events that they say cause their conditions. I'm not an expert on this. You guys can comment on this, but this is a change. It allows for compensation for service members who had good reason to fear traumatic events, even if they did not actually experience them. Okay? And disability benefits include free physical and mental health care, et cetera. So the vets can talk more about that. Cost, what's the cost of PTSD? It's estimated that the societal cost of PTSD and depression among veterans for 2 years after deployment is between $6,000 and $35,000 per case. The total societal costs for 2 years range from $4 billion to $6.2 billion. So this is a significant problem. In conclusion, I would say that PTSD and traumatic brain injury is a little different than Gulf War syndrome, at least in terms of we know what the problem is. It's well described. We've known about it for a long time. We know how to approach its treatment, and we have good and successful treatment mechanisms. We know the barriers to access. We know the personal and financial cost of ignoring the problem, and we know the right thing to do. So the question is, do we have the will and commitment to do it? And I think we must. So let me stop there.
Michael, I think we can take, because Michael, you were really good with time. You finished before I had to signal you. That we could take a couple of questions for a few minutes before George's presentation. So, yes.
I was just wondering what the policy is on PTSD with active duty members of the military.
With what?
Active duty members of the military and PTSD, what the policy is on that. Do they...
In active duty. I'm not so familiar with that, so maybe one of my...
It depends upon how you're framing the questions. Answering the question depends upon how you're framing it. Is the person in the war zone and exhibiting symptoms, or are they back in the United States exhibiting symptoms? So I'll give you two answers. If the service member is in the war zone exhibiting symptoms, what the military is supposed to do is to refer them to mental health and see what they can do either with therapy, talk therapy, or with prescription drugs, and the military tries to keep them in the service. If it's serious enough, then they will medically evacuate them, and in which case they're back in the States. There is an ethical issue, and Professor Ness can answer this. Do you send someone back into combat on drugs, or who is having a serious psychological problem? And the military presently is falling heavily toward the side of sending them back into combat, even though there are some rules saying that they shouldn't. Now, the second half of the question is, what's the military going to do with someone who's back in the States and is now exhibiting symptoms of PTSD?
But they're not in the VA system yet.
But they're not in the VA system yet because they're on active military duty. Okay. The military is generally going to see if they can rehabilitate the service member, either through talk therapy or drugs. Okay? If that doesn't work and the condition is severe enough or chronic enough, the military will make the decision to board the service member out and medically retire them. There was a huge fiasco about this, and where the military was out-processing service members diagnosed with PTSD, but on their discharge papers putting personality disorder, adjustment disorder, or pattern of misconduct. And in those cases, the service members who were about to become veterans would lose a significant amount of their veterans' benefits. Some of that is being addressed now with policy changes within the military. Another huge change that came in the last year was if a service member is diagnosed with PTSD, and that's the reason for their discharge, then the military is supposed to grant them a 50% military disability. The military wasn't doing it for a while. They got sued, and now the military is starting to do it. So there's been an evolution in what the military is doing. The biggest problem is that they are still over-medicating the service members and trying to send them back into combat because of the acute troop shortage.
That's a problem also with depression and with anxiety, same issues.
Michael, you listed a whole set of treatments,
Yeah.
and you said, we know that they work, and some work better than others, but you
Well,
didn't
some
provide
work
any
better-
information
some-
about
hold on,
what.
hold on. Some work better than others in certain people.
Yeah,
We
but I'm
don't know,
saying-
what we don't know is matching which people with which therapy, but we know that the therapies work.
So what do you have data to show that it works, and what does it mean to work?
Yeah,
And so what is it?
yeah. I didn't bring those slides, but we know that, first of all, there's a certain rate of natural remission over time. But it turns out that combat personnel tend to have more of a problem than people who, again, have PTSD symptoms where there's a natural fall-off over time. But again, the rates for PTSD symptoms are, 50% or more in various populations. But it's a very complicated discussion because there's a comorbidity with more major depressive disorder, with anxiety disorder. And so the PTSD is just one part of a whole series of problems that these patients have. But when we've done symptoms on the three, re-experiencing, hypervigilance, and ability to function, there's an improvement.
50%?
Yeah. Again, that's a rough number because it depends on which population, and there's not good matching. But that's pretty good.
Thank you. I liked your slide on what you call treatment failures.
Treatment failures,
Treatment failures,
quote unquote.
right. I would like your opinion on the impact of redeploying someone into a war zone as a potential cause for treatment failure. And then the second is your opinion on the VA's inability to discuss some of the political ramifications or political component of the war. For example, being sent to a war based on a lie.
Sent to a war.
Based on a lie. In other words, there were no weapons of mass destruction in Iraq, and some service members come back, and they're upset that there weren't any, and the fighting and what went on.
Right.
VA doesn't discuss that in therapy sessions. Do you think that what's your opinion on
Yeah, I mean,
those
I
two
think
areas?
there's not specific data as far as I know, but my experience is, and there's some literature to suggest, that belief in a cause is somewhat protective in terms of the symptomatology of all these things. That people who, for instance, we know the population I'm more familiar with, which are people who are torture survivors or refugees, people who are taken off the streets and imprisoned and tortured, who have no way of kind of justifying or putting it together or making sense of it in a kind of a strange way, have an enormous amount of problems. So people who are not committed to the cause, or whereas people who are committed, who are political activists or whatever, tends to be protective in terms of the VA itself. I'm not in the VA system, so I can't really comment on that, so I don't have a personal experience. But what was the other question was? Redeployment, yeah. It's not good. It's not good, particularly when you have constant redeployment. There's never been an experience, you know better than I, but there's never been an experience with this amount of time served and rapidity of redeployment. So this is an experiment, but it's not working out very well.
Okay, thank you, Michael.
Yep.